University Hospital, Taichung, and he's going to give us a talk, laparoscopic liver resection for colorectal cancer metastasis. Let's welcome Dr. Chen.
Thank you for your introduction. It's an honor to have opportunity to have a presentation in this meeting. I think the laparoscopic liver resection is very important because help patients will got liver mets. The first case report is published in 1992, and the first prospective cohort study was published in 2000. And the first Royal Living Donor Hepatectomy was published in 2006. And the first World Consensus Conference was held in 2008. There are three types of laparoscopic liver resection. The first is pure laparoscopic liver resection. We perform the liver resection through the trocar and port and remove the specimen by the standing wound and transverse incision. The second type is the hand assist. And our hand can assist us to mobilize the liver and expose the tumor. The third is a hybrid technique. We initially perform a laparoscope and or hand assist, and then we perform parenchyma transection through a minimal incision. In this consensus conference, they define the three categories. The first is biopsy or small weight resection. The second is resection of left lateral section or anterior hepatic segment, include the 4A, 5, and 6 here. And the third category is hemihepatectomy, trisectionectomy, and the resection of the difficult posterior segment, 4B, 7, and 8. The relative contraindication is large tumor. The tumor located in the posterior superior segment, central locate, and the multiple tumor, bilateral tumor, and the tumor connect with the liver, highland, major hepatic vein, or IVC. But some experts already perform laparoscopic liver resection for this patient. The case number increases year by year dramatically. And the colorectal cancer is about 35% for malignancy. And the most common type is wedge resection and segmenectomy, followed by left lateral section. Some surgeons already perform extended right hepatectomy, caudate lobectomy, and central hepatectomy, and extended left hepatectomy. The most common approach is pure laparoscope, and some surgeons start to perform robotic assist. There was no intraoperative death. The overall mortality is less than 1%. And morbidity is about 10%, including the bileaks and the bleeding. The conversion is about 4%. The main cause is bleeding and the adhesion. The negative surgical margin is about 80 to 100%. The hospital stay is shorter. The benefits include less problems, less post-operative pain, short length of stay, and comparable mobility and mortality. For encouraging outcome, there is a multi-institutional study. The other resection is about 95%. The overall 5-year survival is about 50%. This study compared laparoscope to open liver resection. There was no difference in mean resection margin. The incidence of positive margin is greater in the open group, but this is not a randomized trial. This tri-institutional analysis, laparoscope repeat hepatectomy. The conversion rate is about 10%. Arterial resection about 90%. 5 years overall survival is about 55%. This paper reviewed the laparoscopic liver resection before 2011. There was no prospective randomized trial, only small case control, non-randomized compared study. There was no difference in operative time. The benefit included less paralysis, less post-operative pain, and a short length of stay and comparable post-operative mobility and mortality. There was no difference in resection margin, no post-site recurrence, no tumor seeding, and no difference in 5-year overall survival. The benefit for colorectal cancer is quick post-operative recovery, fewer wound-related complications, and the rapid start of adjuvant chemotherapy. I will demonstrate a laparoscope right hemicolectomy and right hemicolectomy. And 5 chokers, and the first part is the Highland dissection. There are 2 types for Highland approach. One is selective control. One is Gleason approach. In our service, we most of our cases is high selective control. We can isolate the right portal vein and the right cardiac. So I think the laparoscope is safe and feasible for selective control. The second part is the modulation of right lobe. We can elevate the liver and hold the liver with the instrument. We don't need a anesthetic. And then we can easily incise the ligament and take down the adrenal gland. And then it's also safe to isolate the reachal hepatic veins. After this, we can expose the IVC. And then we can loop the right hepatic vein. The third part is the parenchyma transection. There are 3 instruments for parenchyma transection, including the ligature, harmonic stable, and the QSAR. Some surgeons scare to perform parenchyma transection by laparoscope because they scare CO2 embolization. But it's not a but CO2 embolization is different from air embolization. So more and more surgeons perform laparoscope liver resection, not a hybrid technique. And we can divide the right side HD and after parenchyma transection, we can divide the right side hepatic vein. In this case, this is a small tumor around the forehead. So we can perform laparoscopic liver resection. We can remove this tumor as a laparoscopic cholecystectomy. Even this patient ever received open right hemicolectomy. This patient ever received laparoscopic LAR. Then she received a laparoscopic partial hepatectomy of segment 6. Who want to receive open liver resection after a successful laparoscopic LAR? This patient has a small lesion in the segment 4 and the lung metastasis. So this patient received simultaneous laparoscopic liver resection and thoracoscopic with resection of right side. Who won't receive an open liver resection and thoracotomy at the same time? This patient received a simultaneous laparoscopic area and the left lateral segment. We can remove the specimen via the standing umbilical wound. Who want to receive a laparoscopic area and the open liver resection? This tumor located in the difficult part, segment 7. We perform a simultaneous right hemicolectomy and a partial hepatectomy of segment 7. It's very important because a right hemicolectomy will induce a severe adhesion around the right upper abdomen. It's a problem for liver resection. So we need to perform simultaneous liver resection. This tumor located in the deep part of segment 8. And we can perform laparoscopic liver resection and keep a good margin. This patient received neoadjuvant chemotherapy and received simultaneous laparoscopic area and hybrid left lobectomy. This patient has multiple liver mass bilaterally. So we can perform hybrid right lobectomy and multiple wedge resection of leg lobe. This tumor located in the right segment 8. We need a right anterior section, include the segment 5 and segment 8. So laparoscopy is feasible and safe to perform a right anterior section. This tumor located in the left lobe and contact to the middle hepatic vein, left hepatic vein. Laparoscopy is feasible and safe to perform an extended left lobectomy. This is our first case of robotic left lateral segmentation. I think robotic has some benefit. The first is the endoris that we can perform suture and tie easily. The second is 3D, so we can identify and the vessel and the duct easily. At the parenchyma section, we apply the linear carton to provide the pedicle. This is our second case, robotic right lobectomy. Let's talk about the international position of laparoscopic liver resection. This is the second international consensus conference held in Japan. I'm here. There are 200 surgeons attending. The location of prime practice is the academic medical center. The most surgeon was about 40 to 50 years old. 13 centers have more than 200 liver resection per year. And only 6 centers have more than 80% penetration rate of laparoscopic liver resection. The 10 centers have more than 200 laparoscopic liver resection in the past 5 years. Let's talk about the Taiwan position. Now there are more than 2,000 laparoscopic liver resection before 2013. In our center, we start to perform laparoscopic liver resection in 2010, and now we have 200 experience. One center have more than 400 liver resection, and 6 centers have more than 100 liver resection. Most type of approach in Taiwan is pure laparoscopy, and 10% have robotic assist. In our center, most of our patients receive laparoscope, pure laparoscope. And in Taiwan, the major hepatectomy is about 8%. In our series, the major hepatectomy is about 20%. In Taiwan, the tumor located in difficult area is about 14%. In our series, the tumor located in difficult area is about 20%. For colorectal meta, in Taiwan, only 8%. But in our center, 30%. So the conversion rate is about 6%, and the mean hospital stay is 7 days, and the hospital mortality is about 1%. Conclusion: laparoscopic liver resection is safe and feasible for selected patients by experienced surgeon. And the laparoscopic approach is important for simultaneous liver and primary resection. And laparoscope can include laparotomy, especially for carcinomatosis. Laparoscopic repeat liver resection is safe and feasible. The patient can receive adjuvant chemotherapy as soon as possible, and it can diminish stress response. Thank you.
Thank you very much, Dr. Chen. As the next speaker will be Dr. Cai Renshi. Dr. Cai is currently the attending physician in the Department of Colorectal Surgery and of the Changfeng Memorial Hospital in Linkou. Today he's going to give us interest talk. Are we failing our patients? Why colorectal cancer is increasing in Taiwan despite a greater awareness. Let's welcome Dr. Cai.
Today, I will introduce a new technique to detect circulation tumor cells with high specificity and specificity. However, for more easy understanding for Taiwan doctor, later I will speak by Chinese. This causes some inconvenience to the friends come from overseas in other countries. I ask your pardon. Now I will change my language to speak Chinese. 大肠癌的发生率在台湾明年升高，这是大家众所周知。可是呢，我们现在政府施行的癌症筛检，主要是用便捷血反应阳性的检查方式。现在大家知道，便捷反应阳方式灵敏度很低，常常在临床上我们会发现一些癌症的病人，他的便捷反应是阴性，而阳性呢，他检查结果常常是正常的。所以呢，这种情形之下，我们就要思考说，有没有更好的检验方式，可以帮助我们的病人或是一般的大众更知道他癌症的风险性。良好的筛检方式呢，它必须是 non-invasive， 而且可以呢是时常被使用，或是在用在大众身上。最重要，它也必须要 radiation free， 必须要没有放射线的伤害。更重要的一点是说，它对前期癌症的或者是早期癌症病人的诊断率，需要检出率的灵敏度要非常的高。而在这些检验方式之中，血液可能是一个很好的检验标的。在血液中检验血液中肿瘤细胞到底是不是合理？首先，我们要对癌症的发生跟进展有一个详细的了解。首先，正常的癌细胞发生叛逆基因变异以后，它有可能就会形成一个肿瘤。这肿瘤有可能是良性或是恶性。但是呢，在动物实验里面，我们发现说，肿瘤只要有2mm方大小，它的新生血管就可能形成。形成的新生血管，血液中的肿瘤细胞就有可能 到血管里面去，随着肿瘤越来越大，分泌到跑进去血管里面的肿瘤细胞会越来越多，其中存在恶性的细胞也会越来越多。当这些恶性的细胞在远端器官形成肿瘤的时候，就变成转移肿瘤。转移肿瘤的话，它的里面的恶性细胞同样还会再跑进血管里面去，又会形成新的肿瘤存在。因此，在临床上，我们可以明显的发现说，纵使是它是早期癌症，我们在根治性切除手术以后，它还是在几年以后有可能产生转移性的肿瘤形成。所以呢，这就显示说，我们现在如果说针对形成的肿瘤做检查或者做处置，可能是不够的。那血液中肿瘤细胞呢，就是一个新的辅助方式的检查方法，可以让我们了解血液中到底有没有不正常细胞的存在。现在呢，大肠镜的检查可以看到大肠镜中肿瘤有没有息肉，或者是有没有早期的癌症发现。可是呢，在根据美国的统计报告，第一次大肠镜检查的息肉 misdiagnosis rate 会高达33%，而我们的 PET、CT scan 或是各种画像诊断，它所诊断的标的物是肿瘤形成以后的位置跟所在，而对血液中是不是有其他不正常的细胞存在，目前并没有一个好的方式去检查。在血液中检查肿瘤细胞呢，它呢有一个相当大的困难度存在。存在的原因是因为我们的1cc 的血液里面，大概有10到9次方到12次方的血液细胞存在，而其中血液肿瘤细胞的存在颗数可能是0，可能是几颗，可能会几十颗。你如何在10的9次方跟12次方的细胞海之中找出这个微小细胞量的血液中肿瘤细胞？这本身的分离技术就是一个高尖端的分离技术。第二个关键点就是说，你分离出来的细胞是活的还是死的？我们知道，远端肿瘤转移的形成，在血液中存在活的不正常的肿瘤细胞是第一个关卡。所以说，在血液中你检测出有不正常的肿瘤细胞的话，它就有存在那个癌症的风险或是复发的风险。所以呢，两个关键，一个就是说如何分离出来，第二个如何知道说你分级的细胞是活的。那中央研究院基因体中心呢，就开发了一个新的技术，它是用一个 microfluidic platform， 它是一个 chip， 它里面有刻画出很小的微流道，而且这些微流道上面要 coating 一个像类似细胞膜 cell membrane 的一个 phospholipid 的构造。在这个构造上面，它 binding 的 epicam antibody， 当血液注入2cc 的血液，通过这些微流道，如果血液中存在有黏膜上皮细胞的特征的时候，就会被 epicam antibody 捕获。血球细胞因为不存在这个 epicam 的抗原存在，所以它会被流失。其中关键的是说，因为我们上面有 coating 一层特殊的bilayer 的 phospholipid， 所以呢，我们有很简单的 micro air bubble， 我们就可以把这个 cell 从 membrane 上面滤出来，然后给它浓缩，然后给它染色。那我们知道说，我们染色的话，我们用 CK20。我们知道现在 circulation tumor cell detection 方法是 cell search， 现在是 FDA approval。这 FDA approval 它的方法，它就 pan-cytotherapy， 它的 specific 不足，所以很多肿瘤都是非常有。CK20在85% 那个 colorectal cancer 上面，它的 differential rate 是85%， 是病理科用来检测说这个 tumor 是 colon region 还是不是 colon region 的重要 marker。所以我们用这个 CK20当 definition 的话，它的 specific 会 pan-cytotherapy 来得高。那 cell 滤下来以后，我们也有经过还有 clinical 的 test， 它的 viable 的那个程度可以达到90%。然后呢，在这个平台用 cell injection 到 blood whole blood 里面的 spiking test， 它的那个 detection rate 也可以高达60%到70%。这是中央研究院他们的发明，他们有申请专利，那会已经寄转出去。那利用这个平台，长庚医院跟中央研究院就是研究，就是合作这个实验平台 test 这个实验平台以后，我们发现就是说，在 healthy 的病人很少能够检测出超过3颗以上。我们用95%的病人，大概都在2颗1颗左右，所以我们看到的标准值定在3颗左右。在这种标准之下，我们检测出来的结果是，在pretend在 stage 1、2、3的病人 ，stage 2的话检出率大概是60%左右 ，stage 3的检出率是65%，stage 4的检出率大概是80%，而一些良性的 polyp 或者是 dysplasia 或者是 precancer lesion 的话，它的检出率可以达到30%几。如果说用 age adjusted 的 ratio 去统计分析的话，它的 sensitivity 可以达到91%，specific 可以高达79%。那这个检测到底利用在哪里呢？一般来讲，我们现有的检查，大肠癌这边的术后是用 CA 跟画像诊断，而 CA 的话呢 ，the marker 只有50%的病人有用，因为另外50%的病人可能的 CA 不会很高。而画像诊断是诊断说手已经形成了，而且在 PET scan 的话，它的 limitation 大概是0.5公分大小，0.5公分以下的话 limitation 要形成肿瘤以后，你才能够检测得出来。那我们在大肠癌的防治上面，第一个就是如何早期发现癌症的发生，第二个就是说如何早期发现癌症预防的 risk。那这个CDC 的检测就可以运用在我们这个癌症检测，它预测它有没有早期癌症发生，或者是说它有没有可能早期复发里面的危险因素的一个检测方式。而这个检测方式的话呢，对病人来讲，它是非常轻松而可以做的检测方式。这个检测方式呢，目前为止基准给 CMS 公司，所以商业上的话，是由他们在评估说如何应用在病人检测的方法。以上是我今天对大家介绍新的一个检测方法，谢谢大家。
This section will be open for question, discussion, and comment.
我想应该是也不用上去了。Okay. Professor Grossi, may I ask you a question? I'm really interested about the PDL and PDL1 target in MSI high and MCRC. We know that PDL1 and PDL1 is highly related to the immunogenicity. So why do we focus on MSI high patients? Because this kind of patient is very spectrum or relation to the PDL1?
So there are actually already clinical studies underway that focus on, actually they look at all patients, but they more and more focus on the MSI high tumors because, as I mentioned, these MSI high tumors are hypermutated. They look very differently. And if you know from pathology, these are the tumors where you already have a peritumoral lymphocytic infiltration. Those are large tumors which generate an inflammatory response. So these tumors are immunogenic. There's some data coming out of Johns Hopkins, for instance, that show remarkable efficacy of PD-1 antibodies in these MSI high tumors. This needs to be investigated in larger studies. Studies are ongoing from various companies. The PD-1, PD-L1 antibodies it's a very competitive market right now. There's a lot of companies that have similar antibodies. So I hope that we'll be able to find at least this niche for colorectal cancer of PD-1, PD-L1 antibodies.
I ask Professor Wang Zhaoyuan, you have a demonstration of CCRT, the thinner therapy backbone. How do you choose POPOX or PRIDI based on what factor?
Okay. Actually, I have based on our previous previous experience. Now, actually, we have searched the article published in May 9. A small study that compared the KPLs and the KPRIA. Actually, the better response is the KPLs. So actually, we choose the FOLFOX in this kind of patient for the pre-operative CCRT. And most of the study right now is focused on FOLFOX. Actually, the paper focused on FOLFOX is very rich can be identified. So we choose the FOLFOX.
Thanks to all the speakers for giving such a wonderful talk. And I have a question because of the limitation of our health insurance policy in using the target therapy for first line. And what if a patient with wild type but it uses within our guidelines in Taiwan? And I would like to ask Professor Wang that within our I asked Professor Wang and Professor Zhou that within our guideline we have the choice of bevacizumab and cetuximab. What if you contour a patient that with multiple metastases, wild type and unresectable? I mean, even though you expect it is unresectable, what type of choice of target therapy that you would choose?
Actually, if you look according to the insurance coverage in Taiwan, I prefer, you just mentioned unresectable forever, no potential to resection.
Right.
Actually, if you follow the guideline from the government, you know that bevacizumab is approved in the first line, and we have also the cetuximab approved in the third line. So if you concern just the issue of the government coverage, I will have preferred if the unresectable patient using the bevacizumab in the first line. However, if the patient has a borderline resectable, I will choose the patient with the wild type. And right now, every patient I have a KRAS, NRAS, also BRAF test for every one of the cases I have a borderline resectable. I will prefer cetuximab in the first line. That's my personal experience. Maybe not apply to everyone. Zhou, you mentioned for FOLFOX3 in the KRAS wild type patient.
It's quite difficult question to answer because actually I believe in overall survival is most important. The data can achieve the best overall survival is FOLFOX3 plus the Avastin until now. But FOLFOX3 just show the FOLFIRI plus cetuximab shows the best overall survival. In the phase 3 trial is COGB is a big phase 3 trial, but the data is very powerful. Everyone, the FOLFOX and the FOLFOX is quite difficult to predict. So I believe in FOLFOX3 data is more convincing for me. So I will choose the FOLFIRI plus the cetuximab as routine care.
I also have a question for backbone chemotherapy. I want to ask Dr. Grothe. How do you guys choose your backbone chemotherapy? So we in Taiwan, we have been capped with FOLFIRI as well backbone. But in the US, I think you can choose. And how do you choose based on patients' status?
So you know that in the US, 70% of patients receive FOLFOX, 30% receive FOLFIRI. I think the idea came from the initial study, the N9741 study showed oxaliplatin was FOLFOX was better than IFL, and people just made the leap of faith and said, FOLFOX is our standard of care, and then added biologics to it. Then the critical issue is more, how familiar are you with the regimen, and how do you manage toxicities? For instance, especially with oxaliplatin-based therapy. And I think Dan Sargent mentioned, it's a very tricky thing to just believe you can add bevacizumab to FOLFOX and just continue therapy indefinitely until patients progress. They will have toxicities, neurotoxicity before, which limit the duration of treatment, so you need to develop strategies. It's more complicated to do that. So I actually don't really care which backbone you use. You know, FOLFIRI works with cetuximab, FOLFOX works with panitumumab. FOLFOX does work with bevacizumab-based therapy if you use the CHIRO3 maintenance, induction maintenance strategy. Excellent data. I mean, progression-free survival in CHIRO3 was actually about 16 months. So, I mean, this is not bad. So, in the end, it's more your personal experience, how you manage patients, than the actual, you know, whether this is a good backbone or bad backbone. I think the only caveat that I put forward is an oxaliplatin-based therapy with EGF-receptor antibody if you do not have the RAS mutational status, because that's where we saw detriment for the RAS mutated tumors. So in the end, it's more your personal experience. If you use FOLFIRI, so be it. I mean, that's perfectly fine. FOLFIRI-Bev, FOLFIRI-cetuximab both work. And you have second-line approach with FOLFOX bevacizumab, for instance, which is perfectly fine.